purpose of this video is to teach basic medicines reconciliation skills for doctors, pharmacists. It's based on an Australian and UK standard and adopted for local use after many years of tried and tested methodology. The way that we teach this is by highlighting the 5 important steps. 1, 2, 3, 4, 5, 6 important steps. The key points associated with each step and the reasons why these are important. The first thing we do is identify the patient and make sure that we have unique identifiers so as to prevent any drug errors. Where nurses know the patient's weight and height, we ask that they record this on the front of the chart so that we can dose people for treatment of conditions such as thrombus, major sepsis, pain, for example paracetamol, and other conditions. You'll notice that the pharmacists have a section of the chart which highlights when they last saw the patient and the risk stratification that they've designated the patient in terms of frequency of pharmacist checks in the working week. Number 1 priority, as you know, is first do no harm, and in ensuring that we have an accurate adverse reaction history, we are preventing future harm by ensuring that a patient is not challenged by drugs that may cause serious side effects. In this patient, they did develop a reaction, Stevens-Johnson syndrome, or pemphigus, and it was possibly drug related. We had made a note of that without implying causality, and we have also made a note of the date that the consultant's note appears in the patient's file for future reference. You'll notice that the stat medicines are now on the front of the chart. Furthermore, you will notice that a doctor and a nurse and a pharmacist have signed off on the adverse reaction history. As you are taught MedRec by a senior pharmacist, you will be completing the drug chart. You will be verifying the patient's date of birth with them, because it is a very good litmus test for a high chance that the patient may be able to provide an accurate history. If they can't give you the date of birth, they will not be able to give you an accurate drug history. And there's no point venturing any further. You'll need alternative sources of information. Use your checklist to ascertain a full, best possible medication history, ensuring that you're not only finding out what tablets they were on, but the injections, anything they're putting on the skin, whether they're on chemotherapy, anything for the eye, ear, nose or throat, whether they're on patches, inhalers or hormonal therapy, for example. And you'll notice here that the physician has circled whether the patient was taking the drug prior to admission. This is useful for the doctor that is eventually going to do the discharge summary in spelling out the changes that have been made since admission. You'll also notice that when deleting a drug, the physician uses the wave through both the doctor's and the nurse's fields to ensure that everybody knows the drug has been stopped. You'll also notice that when a drug has been stopped, there's been a reason given for it, which is very useful. You'll also notice that this patient is on oral chemotherapy. More of that later. And finally, you'll notice that some medications, additional medications, have also been put on hold, but For completeness, and again ease of reference when the patient is discharged, you have included them, the doctor has included them all in one prescription space and spelt out the 3 that have been put on hold and why they've been put on hold.